History, so you want to know standard things, which knee, how did they dislocate, what's the main factor, is it pain or dislocation? I can make you feel more stable. Whether I can cure your pain is more debatable, and I can't give you a 100% guarantee of that. When was that first dislocation? So again, if they were very young, and sometimes the first dislocators then say, oh yes, but I dislocated once when I was at school. So again, you know that they're going to go on to be the recurrent dislocators. Did they reduce manually or spontaneously? How often and what are they doing? Are they apprehensive? Are they avoiding activities? What's the impact on their life? And any other joints. So again, some of the slightly more syndromic ones have shoulder issues, and I'll send them off to my shoulder colleagues as well. Family history, you often pick up relatives with a similar history. And then what do they want? So what is their ideal outcome in terms of sports, job? Where are they with school and exams and life? So often they're female patients. If they're in the 20s and 30s, they might well be planning a family. How is that going to fit in with your treatment plan? And then the psychology, they can get into a real cycle of anxiety, kinesiophobia, and at its worst, agoraphobia. They won't leave the house. Subluxation or dislocation, so taking a careful history, is it dislocating and popping all the way out, or does it just feel really unstable? Unpick that history with the patients who are paediatric or learning difficulties, and maybe that they're just falling a lot, and that is actually the patella dislocating. And then patient scores, again, we've got lots of scores, a few, so the Norwich and the Banff specific to patellofemoral instability, lots of others such as Kajala, which aren't specific, and they're not very patient friendly. So asking a patient, do you have a flexion deformity? They don't know what that means. Catastrophizing, I quite like to do because it gives me an idea as to how they deal with issues. Are they a glass half empty or a glass half full? That will give you a really good idea as to how they'll cope with a treatment pathway. And then central pain detect scores, because again, if they have an issue with pain, they can get into a really sort of downward spiral, and they can be quite difficult to treat if pain is their main issue. Examination, so standard things, look at them standing. So how do they comfortably stand? If you ask someone to stand, they will stand there with their feet pointing forward. If you ask them how they comfortably stand, you might well find that they stand with their feet pointing out. Also quite interesting to look at recurvatum. You can get quite extreme recurvatum. Depending on your patient population, if you have lots of Afro-Caribbean patients, obese patients, I've noticed a lot of them have recurvatum as well. And gait. So what's your comfy position? Where are your feet in relation to your patellae? And I think that's a really interesting observation. Get them to do dynamic activities. This isn't a static issue. So single leg squats are really useful. See what's happening to the femur, see what's happening to the patella as they do that single leg squat. Pes planus, have they got flat feet? Are they wearing insoles? How do they stand? Really important. And then hypermobility, the extremes will have 9 out of 9. Knee appearance, in the acute phase, if you've got a hemarthrosis, you're more worried about osteochondral defects with a very large hemarthrosis. And then although the guidance is don't aspirate, if it's a very tense hemarthrosis, there is an argument for aspirating that just to get them mobilising and moving quickly. And again, what is the damage to cartilage of a hemarthrosis? That's probably a whole nother lecture. Muscle wasting, if they come in a wheelchair with the leg out straight, wearing multiple braces in pink and crying, they're not going to do well. So stiffness, they've often deconditioned. The ones who are deconditioned and not mobile, they're not going to do well either. And then the loose bodies, floaters, lockers, are they complaining about something stopping them moving the knee? Patella tracking, watch the knee as they actively move it. Does the patella appear high? Is it laterally tracking? Is there a J sign or a clunk? And then does it dislocate in flexion and an extension? Because they're two different beasts, especially in the kids. And it's very much about asking the patient. So if you go and touch the knee, a lot of them will not like it. They'll tense up and then you just can't examine them at all. So a patellar apprehension test, I will ask permission. If they tolerate it, I will very gently move the knee. I will not dislocate it. But again, some of them will not allow you. It gives you an idea of how mobile the patella is. And again, it's a really odd picture. You'll get the hypermobile patient with a hypermobile patella, but you'll get patients with no hypermobility, and then the patella is just all over the place. If they've had a previous lateral release, again, they can be multi-directional instability, so they're unstable medially and laterally, so it's worth looking at that as well. And then don't forget the ACL. So I think it's really interesting doing lots of MRIs of first-time dislocators. You pick up ACL ruptures or partial ruptures, so it is a pivotal injury at the end of the day. Don't forget the ACL. Radiographs, good for picking up those osteochondral defects, as we said, can be quite subtle. And then also this characteristic ossicle pull-off where the MPFL attaches, and that will give you an idea whether it's a recurrent dislocator. We've talked a little bit about shape, so de Jour's classification is one way of looking at shape. And then Oswestry, Bristol is very pragmatic as well. Is it normal? Is it severe? I quite like that. Medial patellofemoral ligament doesn't attach in one spot. It's probably more an hourglass. Do we really know where it attaches in dislocators? Probably not, because most of the studies are in normal patients. MRI, I've often asked our radiologists, can you tell where the MPFL has ruptured? And they're not convinced that you can. What you can pick up is bruising, so that will give you an idea if it's an acute dislocation. Loose body is really important to look at those. They can work their way into the back of the knee, and if it's a child, they can get bigger if they're left. Cartilage damage, as we said, and then the ACL and the menisci. I have picked up a couple of meniscal, very peripheral tears. Measurements, you have different measurements for patella height. Choose what you want, pros and cons of each. Patellofemoral index is also another quite useful way of measuring, so looking at the overlay of the patella with the trochlear groove, but I really don't understand how you can do that if you've got a completely sublux patella. And then sulcus angle will give you an idea of shape. Again, I'm not convinced you can really do that just on an X-ray. Patella tilt, useful, you can do that too. And then looking at the alignment with tibial tubercle-trochlear groove distance, tibial tubercle posterior cruciate ligament distance as well, and then patella tendon trochlear groove. All of these are looking at alignments. With the more severe dysplastic patients, you'd be surprised how often they've got a rotational abnormality as well. And then often with those, we'll do either an EOS or a CT, more so now in the children, and we're picking up rotational abnormalities. So with those, we'll look at femoral anteversion and tibial torsion. And then alignment, just a standing X-ray, either with the EOS if you can do that, or an X-ray. Valgus and varus will again contribute. Treatment, Andy will go into more detail. First-time dislocation versus recurrent dislocation. What's our evidence? It's poor, really. Great, we've done a Cochrane review.